the other speakers and what they've already presented. And Murray, you kind of did my presentation for me, so I don't know. Okay, so when I was preparing for this talk, I noticed that there was a book on my bookshelf that had been sitting there for many years. It was called Endometriosis, so I thought, woohoo, I've got a good start. But it was published in 1984. And actually, when I went through it in the table of contents, the only treatments that were offered in this book in 1984, and I'm assuming that that was kind of indicative of the treatments offered, were surgical treatments and hormone treatments, and there was no mention of psychological treatments or physiotherapy treatments or anything like that. So thank goodness we've come a long way. And yet, right at the beginning of this book, they had some experiences written out in the form of narratives by patients. And when I looked at those, I thought, oh my gosh, of course there's a role for psychology. So that's what I'm going to talk about today. I guess objectives today is to help you understand that clinical health psychology is quite a bit different than other types of psychology, I guess. Touch on some of the recent research on the social and psychological impacts of these disorders, become more familiar. I don't even think I'm going to have to do that with the central nervous system changes with these conditions, understand the psychological factors that can exacerbate pain, and learn about the effectiveness of various psychologically based therapies for chronic pelvic pain and endometriosis. I have to have limitations because this is going to be brief and it's not going to do justice to this area. It's a very complex area. It's really just to review factors involved in this treatment, touch briefly on the growing literature on effective treatments. I have no conflict of interest in this talk. So clinical health psychology is relatively new. It's a relatively new subspecialty in clinical psychology. The emphasis is on the determinants of health, and we provide psychosocial services to facilitate adjustment to disease, manage disease, and definitely pain, and participation, help people participate in their treatment regimens. We help them cope with procedural pain or invasive procedures, and we talk about treatments for specific medical problems. Of course, we're going to have some interventions for mental health issues and issues appearing on medical units. We do both inpatient and outpatient work. And we'd like to do more health promotion and advocacy, and that's always kind of on the back burner. These are just, I just took a few of the medical conditions that we currently work with, and it's interesting, we haven't had a lot of referrals in our department from OBGYN, and I think it's because it's relatively new. We haven't talked about a team approach, but we work with all kinds of different disorders, including complex pain presentations. We have psychologists that do work on various teams. So this is now where I get into this new research and information about these conditions. So I was really happy to discover when I did my lit search that there's a growing body of literature on the social and psychological impact of chronic pelvic pain and endometriosis, and that I thought was very positive. There was a study called the World Endometriosis Research Foundation. Well, not a study, but this was a foundation that was created, and then people were reporting on the findings. And these are some of the findings. And I think that, some of the other numbers I've heard are a little bit longer in terms of the delay for diagnosis. It says here that the mean delay was 5.5 years based on both patient and physician delay. And women frequently underwent more than one surgery. 48% of women in that 931 group of women had reduced work hours. 67% experienced significant problems with partners. 19% considered endometriosis as a cause for divorce. The three main symptoms, and people have already talked about these symptoms: dysmenorrhea, dyspareunia, or pain, having sexual intercourse, and of course chronic pain. Sorry about that. Yeah, and of those with dyspareunia, 80% had to alter their sexual behavior. Interestingly, the effect sizes in terms of the measures of quality of life were comparable to those found in inflammatory bowel diseases such as Crohn's. And when I saw that, I thought, oh my gosh, like this is a really, really important condition for psychology to be involved in. We're very involved with the inflammatory bowel disease programs here at RUH. Other findings from this big review: in order to improve quality of life, medical care needed to address things like emotional, sexual, and social problems, future directions. We're teaching patients how to cope with the pain, as well as how to strengthen relationships with partners and employers, and of course recommended a patient-centered approach with cooperation across disciplines such as psychologists, sexologists, and social workers, as well as all the medical specialties. Another review of the literature, this group reviewed 32 papers using what's called a metaethnography. And a metaethnography is more qualitative, of course, in nature. Really interesting findings. So these were just some of the conceptual categories that they came up with. That there is a relentless and overwhelming pain and a roller coaster of emotions associated with these diseases. The threat to self is the feeling that my body threatens my sense of self and I can no longer be the person I want to be. The culture of secrecy. These conditions have a huge amount of secrecy associated with them. They're not something that you talk about all the time. There's some embarrassment talking about pelvic pain. Needing validation by confirming a diagnosis. I need to know what's causing the pain. Those kinds of things. An important construct is also that women were convinced by others, including healthcare professionals, that their pain was normal and not pathological. They were told that many women get this and that this stuff is normal, therefore get on with it. Women were left believing that if pain is normal, somehow they're to be blamed for their pain and their inability to tolerate pain. These kinds of conceptual categories just helped us understand that these diseases can leave an incredible scar on women. Another meta-review, Cully and colleagues in 2013, the categories that they identified are as you see on the slide there. Just, the impact of diagnostic delay and uncertainty, not being able to plan their lives, impact on relationships, planning for and having children, impact on education. How do you even embark on, a university program or other post-secondary education when you're not really sure how bad your pain is going to be and your ability to attend class or go to work. And of course, impact on mental health and well-being. In all of this, pain was a significant symptom, and I don't think that's a surprise. However, the estimation of pain, and many people have already spoken to this, it's really difficult, it's complicated. We have methodological difficulties in measurement of pain. It's a subjective measurement, and it's always been difficult to measure pain. Incomplete understanding of the mechanism of pain production in these diseases, and Marie talked about just all of the different types of pain, the nociceptive, neuropathic, inflammatory pain, just difficulty in determining the effectiveness of medical and surgical therapies, tendency for chronic pain to progressively involve other organ systems, and the intensity and severity of the pain rarely correlates with the severity of the disease. People have already talked about this, so I don't think that I need to go through this, other than to say one of the first things that we say to any of our patients that we work with is that we believe your pain is real. We are not questioning that. We are just trying to understand what may be triggering ongoing pain. Sometimes, and this is sometimes hard for people to understand, that even your memories of pain, your thoughts about the pain, other things going on in your life that are causing stress can actually trigger that pain response. That's very hard for people to understand. And yet when we say we don't, I mean, we understand, we know your pain is real, we don't blame you for your pain. We're going to try to work together with you to come up with some strategies to help you dial down that pain. We want you to feel like you have some control over your pain, not that the pain controls you. And that's the number one thing I hear from my patients who have chronic pain conditions. They really believe that their pain controls them. And we need to change that together with them. We need to find some strategies that work. I always say, and people have already said this, but without the brain, there is no pain. So right now, all the things that are going on in your life are mapping onto your brain, and we need to change that by changing what we do. Okay. This was just I thought, a really good diagram of just how complicated all of this is when it comes to endometriosis and chronic pelvic pain. And I'm not going to talk about all this stuff. People have already done that. I'm just going to talk about the psychological and cognitive states. So we know that these two conditions, or series of conditions, I guess, may be mediated by psychological and social factors rather than only the pathological findings. For example, it is known that high psychological distress, what we call catastrophization of the pain, pre-existing depressive symptoms and anxiety and poor coping skills can be associated with higher post-surgical pain and endometriosis. In a 2011 study, high rates of psychopathology, including depressive symptoms, anxiety, and poor quality of life, had been reported in women with endometriosis. Of 104 women surveyed, 86.5% had symptoms of depression, 87.5% had symptoms of anxiety. Depression was more prevalent in women with endometriosis who also had chronic pelvic pain than in women without the pain as a result of endometriosis. There is also some association found between endometriosis and bipolar disorder, but they caution that that association cannot be interpreted as causal. These are both quite common conditions among women with in the reproductive ages and are influenced by our ovarian hormones. And some of the medications and some of the, I don't know how you guys say it, but the GnRH agonists that are used to treat endometriosis can also have an effect on emotional ability, or the labile emotions and depression. Other studies that I haven't really reported here in 2014 established that the presence of catastrophizing, feeling that your pain is the worst possible pain and unlikely to improve, can also intensify the experience of post-surgical pain. Mm-hmm. So this is complex. One of the things that we do, I work on the pediatric complex pain team as well. I hope that's not a sign that I'm like... You're done. You got the big message. Not enough words. Can I have that minute back? I'll just keep talking. One of the things that we do in our peds pain clinic is we use metaphor and analogy to help children understand what chronic pain is like. So I usually say things like, okay, when someone rings your doorbell, who hears the doorbell? And I'll say, well, we do in the house, right? And I'll say, okay, imagine this. If someone rings your doorbell and all the doorbells in the whole neighborhood go off, that's what's happening in your pain system, right? Or if you have a broken alarm clock, so that alarm clock keeps ringing no matter what. You turn it off, you unplug it, you throw it out the window, you throw it down the street, and it's still ringing. That's what's happening in a chronic pain condition. Or a car alarm that keeps going off, or a software failure. Chronic pain is like a software failure. When your computer crashes or freezes, it's almost always a software problem, right? The hardware is generally okay. So chronic pain is a problem with the software. It's, if you use that analogy, there's nothing wrong sometimes with the hardware in your body, bones, muscles, organs, but the software that sends messages throughout your system has a glitch. We're going to look at this video because it's an excellent one that really highlights the differences between acute and chronic pain. It was produced in Australia. So, as psychologists, what can we do? Well, we've already seen similar kinds of diagrams. Persistent or chronic pain can result in all of these things, okay? And they all kind of feed each other. So the role of psychological treatments is to really stop that, or to change that to some extent. We know that self-management strategies can be effective, but they're not always sufficient. We need a more holistic approach underpinned by a biopsychosocial perspective that includes emotional support, stress reduction, social support, adaptive coping strategies, psychosexual treatment, and a focus on quality of life issues, sex and relationships, pain management, and career counseling. So psychological treatment should be a standard part of treatments for these conditions. CBT is really changing the way we think about things. Okay. So if we have these troubling thoughts, that this is never going to go away, I can never get on with my life, this is always going to bother me, I'm always going to have painful intercourse, those kinds of things, those are catastrophic thoughts that can actually feed the pain. So CBT helps us think about that differently, and I can't go into all the details of that, but it really is about changing the way we think about something so that we can change the way we feel with our emotions, and that can actually help with the pain condition. There are other things that we can do as psychologists. We can help you adopt some relaxation techniques. These are things I do every day, and I've taught my body, I've taught myself how to better manage anxiety and how to better manage pain. And I really do practice what I preach. Every day when I'm stressed during my day, because I've had a lot of patients to see, I will sometimes just take a 2-minute break and go to my happy place in my head, which is a beach in Mexico. And I come back and I'm rejuvenated, I'm revitalized. I've taught myself how to do that, and that's what I teach my patients to do, is to have a break from the pain, to stop that, the pain cycle at some point in their day, and then to be able to expand on that using a variety of different techniques. We also talk about better stress management, conflict resolution, because all of these things are also triggering your pain response. There were a couple of people, I don't know what country, I should maybe have looked that up, but there was a mindfulness-based psychological intervention for endometriosis. Oh, it says here in Denmark. It was a 10-session intervention, a total of 15 hours of mindfulness training. Mindfulness training was in 5 dimensions, body scan, so they did a nice kind of description of different body parts and how that felt. Breathing techniques, simple version of biofeedback they used. Music to relax, and psychoeducation based on 6 themes, and also had some individual sessions. And they did pre and post measures on a couple of different questionnaires that measure general health and endometriosis specific questionnaires. And this mindfulness-based intervention showed significant and lasting effects on pain levels, well-being, and ability to function. So there is something to that for sure that we need to look at. In our department, we actually use the North Carolina protocol that's called gut-directed hypnotherapy for IBS and IBD, and we've had some really good results with that. And I'm thinking that hypnotherapeutic techniques might be really helpful for chronic pelvic pain and endometriosis because it's basically working on very similar systems. We offer them either individually or in group in our department, and that might be something we can look at. The other thing I wanted to say is that you're going to get a lot of suggestions today, and I think what's really important for you to do is to prepare yourself, get more information if you want, think about the things that you can do, take maybe 1 or 2 suggestions and try some things, just to feel that you may have some control over your pain. If you have problems motivating yourself, then you have to find someone who can help you with that. And that might not be a psychologist, it might be someone else, but at least you can get going. I've got so much else I can say, but I wanted to stop with this, and I wanted to just give you a little story about this. So I'm working with this man right now who has excruciating pain due to injuries he sustained while he was a war veteran. So he's got very bad pain as a result of back injuries. And I've used hypnotherapy with him. It's really changed his life. So I saw him yesterday, and I don't know why I mentioned, I just basically said, have a good weekend. I said, you know, I'm gonna be at a conference tomorrow, and he said, oh, do you know what September 19th is? Arr! And I went, what is September 19th? And he said, it's International Talk Like a Pirate Day. Did you know that? Like, really, this is true. Look it up. It's, and so that's why that's up there. So I just want you to understand that, you know, there's lots that we can do, good psychologically based treatments for chronic pain. And when you see that 5-minute video clip, it's something that we show all of our patients now, and it really helps them understand, you know, how acute pain and chronic pain are different and all the things that need to happen in those pain conditions. So I hope I kept up in my time.